today we're very fortunate to have Professor John Wilding with us this evening to discuss the practice changing STEP1 trial that recently published its results. And John is a professor of medicine at the University of Liverpool, and more importantly is the lead author of STEP1, so it's great to have his insights today. So thanks very much for joining us today, John.
You're welcome.
So we just wanted to have an informal discussion about the implications of these fantastic results from STEP1. But I thought maybe could you just start off with a quick overview of what the aims and objectives of the STEP trial program are?
I think probably most people may well be aware that obesity is a disease that's been kind of lacking a number of treatments. Certainly pharmacotherapy for obesity has been a big problem for a number of years, and we've had a number of drugs come and go for various reasons. Most recently we've had Liraglutide, a GLP-1 receptor agonist approved by NICE for a certain narrow group of people with obesity, attending specialist weight management clinics with pre-diabetes and other cardiovascular risk factors. And liraglutide is reasonably effective. The average weight loss is around 7 or 8 kilos in the scale trials that we use for liraglutide. But many of you will be aware that liraglutide has to some extent been superseded in diabetes treatment by semaglutide, which is a once weekly GLP-1 receptor analog, which seems to be more potent, certainly for glucose lowering. And one of the things that was seen in the trials for semaglutide in diabetes was that there was a lot more weight loss than we saw with liraglutide. So it kind of made sense to explore that as an obesity treatment. So in fact, I was involved and was the senior author for the phase 2 study with semaglutide, where it was actually given once a day in obesity. And in that phase 2 trial published in The Lancet about 3 years ago, we saw really quite impressive weight loss of around 13, 14 kilograms using what is the equivalent of the 2.4 milligram dose of semaglutide weekly, which is used in the STEP program. So not surprisingly, we were all very excited to see what would happen if this was tested in a proper full-blown phase 3 program to find out if semaglutide was effective for treating people with obesity. And the STEP program is actually a whole series of studies, and STEP1 is the first of those studies, looking at semaglutide for the treatment of obesity. STEP2, for example, looks at people with type 2 diabetes. Other trials are looking at use together with a very low energy diet and so on. So there are different study designs within the program. But the STEP1 trial is probably the most straightforward one, just taking people with obesity, without diabetes. A lot of them by chance would have had cardiovascular risk factors, but that wasn't an inclusion criterion specifically. And then just testing to see how effective it is at weight loss, and then looking at effects on cardiovascular risk and looking at effects on quality of life.
You must be delighted with the STEP1 results published in of course, just very recently in the New England Journal of Medicine, and quite spectacular, near 15% reduction in baseline weight with that higher dose of semaglutide, 2.4 milligrams. Can you maybe expand a wee bit more on these results for us, please?
Well, you've already outlined the kind of top line results, which is the average weight loss. But of course, as you will know, weight loss always follows a distribution curve, and there are some people that will tend to do better and some people that will tend to do less well. So in some ways, measuring the success of a weight loss drug, it's actually better to look at what proportion of people achieved a clinically relevant weight loss. And people have always talked about a clinically relevant weight loss as being 5% of body weight. So in this trial, in the placebo group, who all got a diet and lifestyle intervention, just under a third achieved a weight loss of 5%, which is about what we see in most weight management programs over about a year, just over a year. With the semaglutide, and this is the intention to treat analysis, it was 86%. So nearly everybody, a very high proportion. And if you start taking that to higher thresholds, we saw nearly 70% of people achieving a weight loss of 10%. we saw half the people achieving a weight loss of 15%, and we saw just under a third achieving a weight loss of 20%. When you think that a sleeve gastrectomy gives you about 22, 23% weight loss, we're not far, for those individuals, they're not far off what they'd get from a sleeve gastrectomy. Orlistat maybe gives you 5 or 6 kilos of weight loss at best with the lifestyle intervention. The difference from placebo is around 3 kilograms, whereas with semaglutide, the difference from placebo is closer to 12 kilograms. So if you like, you know, you can say it's 4 times more effective than Orlistat, and about twice as effective as daily liraglutide injections, which we've just been allowed to start using on the NHS.
There was obviously significant GI side effects, which is perhaps what we would expect, although I thought the dropout rate was not particularly high. It was probably in line what I was thinking. But it was, I suppose, the thing which caught my eye, we always look for adverse effects. And there was this increase of adverse events in terms of gallbladder disease, which I thought was, again, probably about twice that of what we would see in the high-dose liraglutide studies in scale. Do you have any other insights or thoughts about the adverse effect profile?
I mean, you're right that gallbladder-related disorders, you know, there were more of those seen in the semaglutide group than in the placebo group. It was around about I think, if you put them all together, it was just over 2.5%. So relatively small proportion. It is more than we see in placebo. And the reason for that, whether this is a specific effect of GLP-1 receptor agonists or whether it's a consequence of weight loss, is actually really hard to untangle. I mean, we did that analysis with the scale studies with the liraglutide, and it seemed that the people who were more likely to get gallstones were the people who lost the most weight, irrespective of whether they were on drug or placebo. So it does seem that it's weight loss, and that's been known for years. I mean, we see it very commonly after bariatric surgery. You know, a lot of people after bariatric surgery will end up having, if the surgeon doesn't take it out at the time of the operation, or if they haven't already had a cholecystectomy, they might well get one in the next sort of 5 or 10 years after surgery. So this isn't unexpected. Whether there is a specific mechanism whereby GLP-1 analogs increase gallbladder disorders is yet to be definitively answered, I think. My personal view is it's probably mostly just losing a lot of weight fairly quickly.
The next kind of question I had really was about cardiovascular disease itself and the risks in this group. And a lot of people are saying, fine, okay, you've got some weight loss, but what about the cardiovascular disease? What about the endpoints, outcomes from that side of things? And I just wonder, is that relevant even, I would argue, because do we need cardiovascular outcome trials in this population when we're seeing such significant weight loss and we know there's benefits with that?
That's a really good question. Of course, the majority of people seeking weight loss in the majority of participants in this trial were women, relatively, so about 75% of participants in the STEP1 trial were female, and they have a lower cardiovascular risk. And of course, the average age is relatively young. So these individuals have a relatively low overall cardiovascular risk. We did see some cardiovascular events in the study, but certainly not enough to be able to draw any definitive conclusions one way or the other. There were numerically slightly less in the semaglutide group when you take into account the fact there was twice as many people randomized to semaglutide as placebo, but certainly nothing that you could write home and say anything definitive. I think the concern around this actually comes, again, it's a bit like the story with the diabetes drugs, that there was this trial with sibutramine, which was a serotonin and noradrenaline reuptake inhibitor, which showed an increase in cardiovascular events. So the same kind of concerns have existed around weight loss drugs as have existed for diabetes drugs. And for that reason, the regulators are really quite focused on this. And of course, we know that obesity is an independent risk factor for cardiovascular disease. So it's a reasonable clinical question to ask. And that is actually being addressed. So at the moment, we're nearly recruited, in fact, for the SELECT trial. And the SELECT trial is a study, one of these big international randomized controlled trials of semaglutide, 2.4 milligrams, against placebo in people who are high risk. So these are all people with established cardiovascular disease. And the target for recruitment of that is massive. It's 17,500 people. So that's bigger than most of the diabetes CV outcome trials just on its own. And that trial is, the recruitment is going pretty well. So I imagine we will have an answer to that question in about 3 years' time. Like all of these trials, it's event driven, so I can't give you an exact date, and this is in trial people with overweight and obesity and established cardiovascular disease. So I think that's really, really exciting. And it may well turn out to be beneficial. We know that semaglutide is beneficial in people with diabetes. We've seen that from the SUSTAIN-6 trial. We also see, reductions in improvements in most of the traditional cardiovascular risk factors in STEP1. So we see improvements in lipid profiles, we see improvements in blood pressure, we see reductions in glucose and reductions in inflammatory markers like CRP. So everything is going in the right direction, but we just need to wait and find out whether that actually translates into less events.
John, I wanted to come back to the results that we saw in STEP1, particularly the weight loss. And I was quite interested in the durability, actually, of that weight loss. Do we get any idea? I know it was a 68-week trial, so we're limited to that duration. But did we get any idea of whether the weight loss was sustained over that period? And going forwards in the STEP program, are there any other trials that perhaps might give us an idea of whether if you stop the semaglutide, there's weight regain? Yeah.
So I think the answer is, of course, this was 68 weeks, which is 12 weeks of titration, because it takes quite a long time to build up to 2.4 milligrams of semaglutide. So you have to remember that the titration is quite long. Sorry, it's 16 weeks of titration. So it's a long titration period. As we do with semaglutide in diabetes. So it does take time to build up to the maximum dose. And then we've got a year's data. There are other studies that are going to go out to 2 years. SELECT will give us data in that high cardiovascular risk population up to about probably 4 years or so. So we will have some longer term data. There is one study which is not yet published, but which has shared some of its data, where there was a group of people where semaglutide was stopped. And when you stop semaglutide, even if you continue the lifestyle advice, you've taken away the drug. And exactly as you would, if you put somebody on an ACE inhibitor for hypertension, you don't expect the blood pressure to stay down when you stop the antihypertensive. If you stop the ACE inhibitor, the blood pressure goes back up. And that is probably the same with semaglutide or with any weight loss drug, actually.
So is there a suggestion there, perhaps, that you would consider this potentially as a long-term medication?
Yeah, I think you could
is that
use
something that you suggest?
And that would be the way that it was, much as the same way as we use the same group of drugs long-term in people with diabetes. So I think that is certainly the intention. The other way you could do it, and again, there's no trial data to support this, but it has been done with other drugs for weight loss, is to actually use it intermittently. So you would maybe set a threshold of weight regain and then say, okay, once you've regained 5% of your weight again, then you go back on it, and that way you'd end up sort of bobbling along the bottom rather than sort of regaining all the weight, because we do know that the physiological pressures, if you successfully lose weight, the physiological signals to take you back up to your previous weight are very, very powerful. And one of those signals, of course, is lower GLP-1 levels. So to some extent, the reason why this works is it's blocking that physiological signal, that would normally take you back up to your previous weight.
Yeah, it'll be interesting to see how that plays out, especially I suppose with lifestyle interventions going on parallel to that, and obviously the access to those in the community.
Yeah, and of course we do need to make sure that, you know, just generally across the NHS, that lifestyle interventions are available and easily available. You know, the data that supports them, you know, for example, in pre-diabetes is really strong. They don't give you massive weight loss, but they are effective for preventing diabetes. So from a, you know, population risk strategy, they're a good approach. But of course, the people that I see in specialist weight management clinics, most of whom have a body mass index above 40, many of whom have a lot of the complications of obesity, like diabetes, pre-diabetes, sleep apnea, joint pains, arthritis, depression, you name it, they've got it, unfortunately. For those individuals, a lifestyle intervention that gives them a few kilograms of weight loss is not going to make all of those problems go away. It can improve their quality of life. It's not a waste of time, but for the majority of people, that is not going to be sufficient. Some of those people will choose to go down the bariatric surgery route, which is effective. But I would say, even if you look around the specialist weight management clinics up and down the country, the proportion of people who actually end up having bariatric surgery is still probably only 10-15% at best. So the majority of people are going to need something else. And I think this would fill that gap between the relatively weak but still worthwhile lifestyle interventions and the very powerful but not for everybody bariatric surgery.
Is this something you foresee the three of us initiating in primary care in the future, or will it be very much the realm of the weight management services, tiered weight management services?
Yeah, I don't see any reason why it couldn't be initiated in primary care. You know, in Liverpool, our specialist weight management services, some of them are secondary care led, but one of our services is all of the clinical input is actually from primary care, from GPs. And GPs have, you know, with a little bit of training and some support, are actually very, very good at supporting people with obesity, especially if they've got a multidisciplinary team around them. So I don't see any reason why this couldn't be used in primary care.
I mean, in terms of accessing it in primary care, I suppose what we've often been driven by is the likes of NICE telling us what's cost effective. And as Kevin has already mentioned before, we've got one treatment which is been in the past deemed cost effective in primary care, i.e. Orlistat. And then we've got in specialized clinics, we've now got access to 3 milligrams of Liraglutide. Where do you think this will be? I suppose I'm asking a similar sort of question, but in terms of what patients do you think we're going to be using it for? I suppose I understand in terms of what tipped the balance for NICE to come down in favor of Liraglutide was pre-diabetes. Is that a cohort which you think would be appropriate for us to look at for high-dose semaglutide, or other characteristics which you think will drive that cost effectiveness?
That's a great question, and I think you're probably right that pre-diabetes will be one of those groups. I mean, of course, at the moment we've got diabetes prevention program, which is running within the NHS, but maybe for some people where maybe they've tried that and it's not given them much of an effect. And then the people with more severe and complex obesity who are at a higher weight, where perhaps it's harder for them to engage with that sort of program, and they need more support, when semaglutide might be more useful. But I don't necessarily think we should be using just BMI cutoffs. You know, BMI is a very poor measure of the disease of obesity, which is, you know, defined as excess fat causing ill health, and the BMI actually doesn't come into the definition at all in the sense of the disease, but it is quite a convenient way of classifying people. It's easy to measure, and therefore we use it. but I'm not sure that it's the best measure. I think we probably need to be a bit more sophisticated than that and look at staging systems or scoring systems to identify the people who are most likely to benefit from this. One thing I will say is there's another group of people who will almost certainly benefit from this, and there's another study that was published a little bit before this one in the New England Journal, which looked at semaglutide 2.4 milligrams for people with non-alcoholic fatty liver disease and showed benefit in that group. So of course that's another group of people where this might be particularly useful.
From what we've seen with semaglutide, where would that fit in consideration for surgery? Would you use it first, or kind of, obviously the people who can't go for surgery, fine, but does that mean everyone should be thought about for surgery first and then this, or beforehand, or what? Just thoughts on that side?
So that's another great question. I think there will be some people who might say, well, I'm really not quite sure about surgery. Let me see how I feel if I manage to lose, because I might be one of the people who loses 20% with semaglutide, and that would not be as much weight as I'd lose with surgery, but it might get me to the point where I feel that my quality of life has improved, and I'm well enough to do what the things I want to do, and I've reduced my risk, and I'm really happy with that. So that would be probably the group where we'd use it most. But I think you also perhaps need to think, and again, this is a question for the future, is whether it might be useful in the group of people who've had surgery and who are having problems maintaining the weight loss. And again, there are some studies with liraglutide, very small studies that suggest that that can be useful. And certainly we've used liraglutide in people with persistent diabetes after bariatric surgery and find that it seems to help maintain the weight loss in those individuals. So it can be useful. And I don't think there's any major concern about using it in that group as long as it's tolerated.
And there's comments on that GLP-1 response, isn't there, with bariatric surgery, and whether that had some impact on that as well.
It's interesting because after bariatric surgery, GLP-1 is initially very high, but then it tends to sort of drop back down to normal levels sort of a year or so after surgery. So it's probably part of the initial response, but probably not part of the persistent reason why bariatric surgery works.
John, I just wanted to pick up on the pre-diabetes cohort again, focusing on step 1. There, between 40 to 45% the participants had pre-diabetes. I was just wondering whether we can get any messages from the data of whether patients with pre-diabetes would regress to normoglycemia, what proportion?
We did look at that. It's actually in the appendix, and yes, we do see a greater regression to pre-diabetes, from pre-diabetes to normoglycemia. And in fact, that's a further analysis that is ongoing. We're going to look at it across the STEP program. It's not complete yet, though.
And how about the other way, prevention of progression to diabetes? Is that something that's being looked at as well?
Yeah, we see that as well. So you get regression to normoglycemia and less progression to diabetes.
Back to my point, kind of saying, the cardiovascular outcome trial might add something, but it doesn't take away anything if you don't have those cardiovascular outcomes, would you say? Because of what we've seen with this.
Well, I think it's important to show that it's safe from a cardiovascular perspective. I'd be really surprised if it wasn't, given what we already know about this class in diabetes. And I think there's a reasonably good chance that it will actually show benefit. Whether that is through the traditional risk factor improvement and the weight loss, or whether it is the independent effect that GLP-1 appears to have on the heart and the vasculature, or a combination of the two, is a scientific question that probably won't even be answered by the trial. The trial will just give us a heart attack count and a stroke count and a number of people who've died of cardiovascular disease, but it won't tell us why.
So we've got, obviously, step 2 is high dose semaglutide in people living with type 2 diabetes. We've got some, I think there's already been an announcement by Novo in the last year, and the weight loss wasn't quite as impressive, which we often see in type 2 diabetes studies rather than obesity, straight obesity studies. I mean, what's your, what's your comments really, I suppose, on what we see?
Well, that doesn't entirely surprise me, and obviously, that those data will be published, I hope, quite soon. So we'll be able to interrogate them in a lot more detail when they are published. But I think it's one of the things that we always see, that people with diabetes, if you put them through a weight loss program, they seem to lose a little bit less weight than people without diabetes. The reasons for that are probably quite complex. That they've clearly got higher numbers of other comorbidities that may make it harder for them to comply with an exercise program. Some of them may be on drugs like sulfonylureas and insulin that make it harder for them to lose weight. And I think and there may be other physiological reasons why it's harder for people with diabetes to lose weight, because clearly those individuals have probably got a bigger impact of their obesity related disease already. So it kind of doesn't surprise me that it's a bit harder to treat them. You mentioned the sort of dual agonist, and I think there is some really sort of exciting data that we're just beginning to see the sort of tantalizing hints of with drugs like tirzepatide, which is a GLP-1 GIP agonist. We're seeing the GLP-1 glucagon agonists as well. Maybe those will be less useful in diabetes, but the weight loss for some of those combinations is looking quite good. And I do know that some companies are looking at other combinations. So GLP-1 with amylin, for example. We already have pramlintide in the US as an amylin analog for type 1 diabetes. But amylin has been tested and seems to produce some weight loss. So what happens if you put that together with GLP-1? Peptide YY is another one of the gut hormones that's involved in the satiety cascade. What happens if you add that in? And then it may actually be that we end up with, I mean, people are even talking about triple or even quadruple agonists that will actually give us the sort of weight loss that we see with bariatric surgery. And I think that, as we've seen, we've seen this with COVID. If the biotech industry decides it wants to do something and if you put enough investment in, it'll do it. And these are tractable targets, and I think it's from a pharmacological perspective, it's not a case of if, it's a case of when. I think it just may take a little while.
John, I was just going to quickly ask you something before I hand back over to Kevin. Semaglutide, we know that there's also an oral formulation that we use in the management of type 2 diabetes. Has there been any consideration of high dose oral semaglutide for weight loss?
As far as I'm aware, that's not in the pipeline. And I think the reasons for that are probably because I suspect that, I don't know that, this technology that they use, this SNAC technology as it currently exists to get the peptide across the mucosal barrier is probably being pushed to its limits with the 14 milligram dose that is used with the oral semaglutide. It's an amazing technological success, and obviously for some people it will be really, really useful, but the numbers of people that are probably going to benefit from that in diabetes is probably still going to be quite small, I think, but I'm not sure that it's going to be technically possible to do it with semaglutide. But having said that, I've just said to you that I think that if there is a way of doing it, and if the industry keeps working hard enough, I think it's going to get better. We're hearing now about another, new attempts at oral insulin that seem to work, even in limited form at least. So I suspect that, again, we will see advances in this area over the next few years. So I'd never say never, but sometimes these things take a long time. Oral insulin has been through ups and downs, for as long as I've been in diabetes, which is quite a long time.
Good stuff. No, thanks. Yeah, certainly between the four of us, we've chatted about this. We have a fair amount of experience now of using the oral preparation of semaglutide, and certainly I'm sure I share everyone's thoughts. But we don't feel it's the sort of a panacea to type 2 diabetes, but a really useful additional tool to have in our toolbox to tackle type 2 diabetes.
Absolutely. And in fact, I was seeing a patient today where it might well be the solution, because she's just so needle phobic that the idea of doing an injection is just is going to be a real challenge.
Yeah. No, I was just going to thank Joe, and I'm actually on behalf of my colleagues. Thank you so much for your time. Much appreciated, John. Great to hear your insights and future predictions, really, about what sounds going to be an incredibly challenging and busy time for us all in primary and secondary care. And perhaps from what you're saying, bariatric surgery in the future may well be made redundant with all these fantastic pharmacological options. Alma sounds like he disagrees there. So thanks again, John.
Thank you very much.
Thanks for joining us.
Okay.
Cheers.
Thanks, John. Thanks.